All right, everyone. Bill Hanks here with Dr. Gina Pritchard, and she is going to be with us, and we're going to be talking about optimizing everything cardiovascular-wise. She is the owner and operator of the Prevent Clinic up in Dallas, Texas, and we met through some of our epigenetics training that we did in Florida, and kind of got to know each other. And hold on just a second here. Facebook requires you. Okay, we are live. All right, so
technology.
Yeah, technology is always something that goes on with it. You think that you got it figured out, and then something happens. But anyways, yeah. So we were just going to talk about cardiovascular health, optimizing it. Obviously, at Huemn, we're always looking for the things that work best in today's environment. It's always changing, always evolving, and so nothing's ever the same. So, Gina, if you want to just give us a little background about what led you to cardiovascular health, and just why you picked this as your business, and what your passion is behind it, and tell us just a little bit about that.
Okay, thank you so much, Bill, for having me today and for this opportunity. And so, yes, I'm a nurse practitioner with my doctorate degree, and I actually was drawn to cardiovascular health when I was a junior in high school, because I went through a nurse's aid program during the summer between my junior and summer year. And I just thought, you know, the EKG, or the telemetry, that waveform that measures your heart rate, I'm like, I want to learn to read that. It was very intriguing to me, while at the same time, one of the first patients I was learning on had end-stage cardiovascular disease, and she suffered so that dramatic summer and that experience drew me to cardiovascular health. Little did I know, fast forward to today, that not only would all that I learned throughout my nursing career, and as you said, still learning, because things are ever evolving, would it impact my patients' lives, but my personal life as well. As it wasn't until I was a registered nurse and going back for my nurse practitioner, actually, at some point, that I realized the severity of the possible impact of my family history, of the worst family history ever. And so nonetheless, I rounded in the hospital as a nurse practitioner for many years. First worked in the hospital as a registered nurse in the critical care unit and the cardiac catheterization laboratory, where stents are placed, for example. And it began to feel like, after about 20 years of that, like a revolving door. We just knew when patients came in with their first heart attack, they would come back with another, or they would come back for another stent procedure, another bypass surgery. And I began to seek out, this was like in 2005, I began to seek out who's really doing a better job at keeping people out of the hospital than we are, because I've worked in everywhere from rural facilities in East Texas, as well as metropolitan teaching hospitals, and everywhere thought, you know, we're great, we're on the cutting edge, and yet it just didn't really seem like we had a long-term solution for people. Once they had that first episode, it's like it was the beginning of the decline. Not that they would be dead in 10 years in every case. Sometimes it was just a stent for angina, and they would be maybe good for 2 or 3 years, but there would be another problem in the future. So what we know today, and what I learned since 2005, is that we're doing a very incomplete job of understanding and evaluating someone's risk for cardiovascular disease. Heart attack and stroke still remain the #1 killers and cause of disability in the United States. 2,500 people a day die from heart attack alone. And it's just, if those numbers were in front of us every day, like these COVID virus numbers are, right? If they had been prior to, it's like, we got to do something. Or perhaps, you know, I or my neighbor or my spouse, my loved one, could succumb to that. And there are very powerful tools today, technologies we can understand. And I would say we can eliminate at least 80% of the heart attacks and strokes that are occurring. Sometimes I use a tagline, or a headline, if you will, and maybe it's kind of dramatic, that heart attacks are optional, strokes are optional. But truly, unless it's related to like drug abuse that, causes strokes many times, or heart attacks, or a congenital anomaly, certain things that we can't control for, but at least 80% of the heart attacks and strokes occur from things that we can change. We do have control over that. So while we know that the majority of the population, somewhere around 90%, that last 10 or 11 years of their life is often impacted by either this disease or others, but oftentimes it's cardiovascular disease or vascular disease of some sort. So you and I are committed to not only longevity, but to vibrant health to your last breath. And so if we're going to have vibrant health to our last breath, we have to address this disease. We love more to talk about peak performance and health optimization. I do too. How can I get better? And how can I feel more energetic and look better in the mirror? All those things are incredibly important, and they do impact our health. But unless we unfortunately talk about disease, because it is epidemic in the United States, and what we can do to identify it and correct it, those last 10 years could be miserable, or, certainly you could die prematurely from one of these terrible diseases.
Well, yeah, so much to unpack there. I mean, it's, first, like you said, with the COVID, and just the way that we look at the numbers here in Harris County in Houston, I think we've had up to 300 deaths, and that's where we're at right now. And I can guarantee you, since this whole COVID kicked off, we've probably had 10x, of cardiovascular deaths. So
right,
it's not like we're giving it the weight that it deserves. So there's so much there that we need to do. And like you said, if we were running a ticker on this, you would just see this explode, so it's just not getting the press, or whatever you want to call it. I guess we've just accepted it as the norm. And so we would like to disrupt that, and like to say, hey, these aren't your, this isn't your fate, and you don't have to choose that. So on that topic there, kind of gets back to where we met with the genetic side of it.
Yeah.
And, one of the genes we always discuss is the ApoE gene, and ApoE4, the ApoE4 variant. And so regarding that, and just kind of, what you're saying, I think people need to know that, even though you have the genetics, right, that might lead to poor cardiovascular health, there's always a way through that. Is that the case?
Absolutely, that's the case. Over the years, I've had several patients. It's not the majority, but there are a significant number of us that carry the ApoE4 and other genetic markers that we know markedly increase your risk of cardiovascular disease or demise from heart attack, and had plenty of those. None to date have had an event, have had a heart attack or a stroke. And even the ones that have come to me after they've had problems, after their first heart attack, if they carry that genetic variance, it's one of the pieces of the puzzle for us to understand perhaps why they went down that path. But you can still control your future with this epigenetics, as you're speaking of. If you can find out the root cause of the problem, it just a genetic predisposition does not have to manifest itself. That's for sure. Of course, there are a lot of people that take peace of mind in not wrong things, but the incomplete things. In other words, I have some athletes in my practice. I have some people that are incredibly clean eating, people that you would say, that's the healthiest person I know, or that's the healthiest person on my block, or the healthiest person in my family, or whatever. And of course, we know Bob Harper, the celebrity personal trainer that, had a heart attack, and others. So to say I'm protected, even though I have genetic predisposition, because I eat clean, I'm working out, I'm sleeping well, I feel like I've got a handle on my stress, perhaps a thorough evaluation from the beginning hasn't been done, because there's some more obscure root causes. So when people come to me and they say, well, are you just going to give me a new diet, or, you know, kind of what are you going to tell me? Well, I don't know really until we start with understanding what's going on in the inside of you.
Right. So one thing I want, before we move on, I want to just double click on Bob Harper. Some people may not know him, but he is I want to say he's like in his 40s or 50s, and he's a CrossFitter, and I know a lot of CrossFitters because I do CrossFit. Very healthy guy. You would look at him and you would say, no way does this guy have any kind of issues. He works out 5 times a week, 6 times a week, and which may be too much. We'll talk about that. But you know, he ended up right in the middle of his you know, being a celebrity and helping people and all that stuff. He ended up having a heart attack himself. Can you just kind of tell us a little bit more about what happened there?
Right. Well, I certainly don't know his case thoroughly, right? But I do know that one of his issues, because you see him speaking about this, one of his root causes or contributors to the problem, if you will, was lipoprotein little a, which is a genetic variance, if you will. It runs in families. And so when your physician or your nurse practitioner or your PA, or you're going to Huemn and getting lab work performed, I know you do some lab work there, or getting started with some things. If a lipid profile is measured, total cholesterol, the good cholesterol, HDL, the bad cholesterol, LDL, and the triglycerides, that's a traditional lipid panel. But it's incredibly inconclusive if a lipoprotein little a isn't measured. It's a very inexpensive test. So be sure and ask your healthcare provider to run that test on you. So this LP little a that Bob Harper has, one of my colleagues that a lot of my work is based on, Dr. Bradley Bale, and his associate, Dr. Amy Doneen, they stay very current on all things cardiovascular health. And he actually loves to nickname things. And it's not really funny, but I can see him very passionate and talking about this lipoprotein little a problem. And he calls it the mass murderer. And that's because if you carry this lipoprotein A, then you are incredibly likely to have a heart attack at a young age. So had Bob Harper not been as healthy as he was, he probably would have had trouble sooner. It's it's pro-inflammation, and it causes trouble, if you will, inside the wall of the artery. It causes the artery to be inflamed. And it's an LDL particle, you know, just a bad cholesterol particle. And we all have proteins off of our LDL particle, but this particular one has a long corkscrew shaped protein that catches on the artery wall, it digs into the artery wall, and allows this LDL particle to really cause trouble there, create a sore, if you will, and plaque in the arterial wall. So that was one of Bob Harper's main root causes. I do know that just because he speaks on it all the time.
So let me ask you this. So, and you may not know his case specifically, but like if someone had an LP little a issue, right, and they got their LDLs and they're looking at their lipid profile and everything looks pretty good. They look like they're in ranges, or you know, nothing looks extraordinarily out of whack. But let's say, for instance, would inflammation show up? Like, would a higher CRP kind of give you an indication that, hey, maybe we need to do a little bit more in-depth analysis here, or would that not be the case?
So it would, especially if LP little a was, as I said, causing problems in the wall of the artery, was stirring up inflammation. Then a C-reactive protein may or may not show it. And we can talk about inflammatory markers in a minute if you want, but there's at least 4 that are really specific, or 3 that are very specific for the artery wall. And so if those are elevated, then, and you have LP little a, then those are patients that I say, if there ever was, like I know you've come to see me for prevention and health optimization, but when I get that result back, if I have inflammation that's elevated, I'm calling them on the phone even before their appointment, saying if there ever was a prevention emergency, this is it. Because when you have elevation of the wall of the artery, that's what could start a blood clot, a cascade of problems leading to heart attack. You're fine today and you're not tomorrow. And so, yes, inflammation is key. The other thing about Lp(a) is if it's elevated, you can take niacin. Exercise is very good at mitigating the dangerous effects of Lp(a), but also vitamin B3, which is in many of our multivitamins. A lot of people are on a B complex, but in order to mitigate the dangerous effects of Lp(a), you have to take pretty high doses. I start patients on 250 milligrams at the lowest. And that's the one that can give you kind of the hot flash, itchy skin kind of feeling when you go up to those kind of doses. And you need blood work because it can affect your liver. So you have to be cautious. I never seen that, but my colleagues have. So you do have to check liver enzymes and things when you go to those doses. And people up to, we titrate up. Some are up to, very few are up to 3,000 milligrams. Usually the dose is around 1,000 milligrams, but it works wonders. It's all we've had for years. There are some other supplements that have some beneficial effect on Lp(a) as well, but niacin is the biggest bang for the buck.
So niacin is B3 or? Oh, okay. Yeah. I just wanted to be sure. And would there be any risk of taking this dose if, you didn't have any issues or anything like that? Is it?
No, it absolutely, I would say, is the best cholesterol medication we've got. It moves everything in the right direction. It lowers total cholesterol. It raises HDL, the good cholesterol, lowers LDL, the bad cholesterol, lowers triglycerides. So everything goes the right direction in your cholesterol profile besides this beneficial effect on Lp(a). So I use it a lot. It's gotten really bad press in the last 2 or 3 years because of a paper that came out that says niacin isn't good, it's not helpful, throw it out, and it, in fact, could be dangerous. But in that study, if you look closely, it was not truly a study of niacin alone. It was niacin attached to a different drug. It was really a combination drug. That was this attachment of this other drug was supposed to reduce the incidence of this hot flash some people can get on the niacin.
Wow. That just goes to show, like, you just can't take the headline. You've got to always, dig in a little bit deeper and use critical thinking and not just take everything from what somebody's saying. And so was this a peer-reviewed study or really? Wow.
It was pharmacy funded, of course, and I'm not really just bashing pharmacy because we've got some great medicines, and I do use prescription medication. I don't like to, but I have to sometimes. If it's between that and I can't ensure that you're not going to have a heart attack or a stroke, of course, we have that discussion. But it was peer reviewed, controlled, placebo controlled, blinded study.
Yeah. Yes, you always have to have your critical thinking hat on and what's being presented to you. So that's a good point.
True.
So what do you think about stroke? Right, we've talked a little bit about cardiovascular health. How does that fit in with everything that we're talking about right now?
Right. So again, about 80% of strokes occur from this problem in the artery wall. In other words, we think that we get plaque, and for whatever reason, I have a family history, I'm going to have atherosclerotic plaque. I'm going to have a buildup of cholesterol in the wall of my arteries. It is incredibly common, right? Especially in the United States of America, worldwide, but it's incredibly common to have plaque in the wall of the arteries, but it isn't normal. I have had some elderly people that we've looked everywhere we know to look, and we can't find significant vascular disease, so atherosclerotic plaque. But even if you have a small plaque, let's say the blood vessel is wide open, this plaque isn't blocking your artery 80% or 50% or even 30%. It's a blister-like. It looks like a little blister on the wall of the artery. And if you're looking at your like ultrasounds and things that look at the wall of the artery, the cut point really is 1.3 millimeters for those listening who may want to know. If you get an ultrasound and they say there's mild plaque in the artery, 1.0 millimeters. Okay, it's thickening of the wall of the artery, but it's really not that dangerous plaque yet. But all experts agree, once it measures 1.3, then it's a plaque. And the reason that's important is because even a 1.3 tiny little 1.3 millimeter plaque, if it's got a soft cap on it, like a blister, it can rupture and you could be dead in minutes. Because if it ruptures in a blood vessel giving the blood supply to the heart, then it's a heart attack.
Wow.
If it ruptures in the blood vessel giving the blood supply to the brain, then it's a stroke. So that is the same problem, stroke or heart attack. And that's the problem that occurs in 80% of people. That's why my practice is so focused on baseline understanding of what do your arteries look like, the person who's sitting in front of me today. And when we look again in a year, we want to see improvement and certainly no progression. And that's how we monitor reversal of disease if you have it, or maintenance of healthy arteries if you don't have disease at baseline. But the other things that can cause stroke, and answering your question, certainly the next most common cause of stroke is high blood pressure. So you can have a hypertensive episode and perhaps even feel fine or feel a little bit of a headache, or maybe you feel a little dizzy or something. And that can cause a stroke. And that problem is because a blood vessel bursts and you actually get a hemorrhagic stroke, bleeding into the brain. But this problem of the opposite problem, a little plaque that's growing and that's possibly building little clots on it. If it produces a large clot that immediately blocks the flow of blood, you have a stroke. But an important point about that is you and I sitting here, people that are, anywhere from, well, any adults, but certainly this risk gets greater the older we get. This process could be going on a daily basis. It is in most of us, where the body is constantly protecting us by a little plaque on an artery wall rupturing, and you put a little clot on it and you move on with your life. You don't even know what's happening. The body is protecting you. But the significant point about that is if this occurs for years and years, eventually that will cause dementia and or a stroke, a heart attack, or heart failure, because you're just chipping away at these small blood vessels in the brain and small blood vessels in the heart, and you knock off one capillary because this process has been going on chronically for so long. Plaque, clot, plaque, clot, plaque, clot. So it does slowly block off the flow in that small little branch, if you will. So once that goes on and you knock off enough, you stop blood flow enough, then you've got a little area of the heart that doesn't work quite right. You've got a little area of the brain that doesn't work quite right. So these issues are important for the sudden onset heart attack and stroke, and it's important for the long-term dementia problem, as well as heart failure, kidney disease, it can affect any organ.
So yeah, we hear about that a lot with just Alzheimer's and the plaque in the brain, and so that makes a lot of sense to me. It's like shutting areas of the brain off, right? It's no longer getting communication. So optimizing for blood flow and optimizing for arterial walls and all that seems like it would continue to help that. And so, this all is related to cardiovascular health. So I guess what I'm hearing from you is it's not so much you're just focusing on the heart, or you're just focusing on stroke, or you're just focusing on blood flow, right? In arterial walls, and just like making sure, everything that is supposed to be delivered to where it needs to go is being delivered. And we had a conversation with Dr. Thomas, and we talked a lot about nitric oxide, right?
Yeah. Critical.
And so important. And the way we described it is like, it's kind of like the oil in your car, it's going to help facilitate all the movement of blood flow and all that. So where do you see nitric oxide, and what do you monitor with that?
Right. Nitric oxide, critically important. I say it's our body's own endogenous like nitroglycerin. You know how people take nitroglycerin under the tongue if they have cardiovascular disease and they're having angina or chest pain? They'll stop, take a nitroglycerin, and then the chest pain will go away, or the shortness of breath, they'll be able to move on. Nitric oxide works very similar to that because it's got so many roles and responsibilities in maintaining arterial health. You're exactly right. My focus is, of course, on brain and heart health and kidney health. We have to look at all of that, but first and foremost, how healthy are your arteries? And if you're low in nitric oxide, then you know immediately this person can't have ideally healthy arteries. The nitric oxide is necessary to reduce inflammation. That there's a little lining called the endothelial lining. It reminds me of the little lining on the inside of your cheek, and that lines the wall of the artery. And if you're low in nitric oxide, then your entry point for plaque into the wall of the artery is vulnerable because it's more likely to crack and not be healthy and allow things to penetrate like cholesterol particles and other debris that you don't want in the wall of the artery. So nitric oxide, incredibly, incredibly important. And I measure it with the saliva strips. I know there are other ways, but I like those. Yeah.
And then to increase it, like say you have a client you want to do it, what do you suggest?
Yeah, so there's really three things I focus on. And one is you can make a significant increase in your nitric oxide by eating more nitric oxide boosting foods. And those are the dark greens and beets primarily. One reason beets have taken a kind of a new, I don't know, become more popular, and there's all kinds of beet products you can get and things. So dark greens and the beets, if you don't have that in your diet, find a way to put those in your diet. The second thing is one of the, I would say, less often thought about and less often looked at, but perhaps the most significant issue that impacts nitric oxide levels is actually mouth breathing versus nasal breathing, or any impairment in breathing, such as a small airway or sleep disordered breathing or sleep apnea. So a lot of times I'll send patients just for coaching on breath work to focus on closing the mouth and breathing in and out through the nose. You need to breathe in and out through the nose in order to get the nitric oxide level up there. So food, are you a mouth breather? And do you have any issues? We oftentimes send people home with a home sleep test if they don't have a wearable that's giving us enough advice, enough information, or even occasionally a formal sleep study. And there's a test called a cone beam CT that's performed in the office of many dentists or airway experts to evaluate the structure of the mouth and of the airway. To many times it's a structural problem that your dental colleagues can address. So everybody that comes to my practice, those issues need to be evaluated.
Right. So it'd be, you kind of take a step phased approach where, you obviously need it in your diet. And if you're putting it into your diet, but you're still not getting nitric oxide, you want to just keep continuing down that path. Now, one thing I will say that I've been committed to for, probably about 3 years now. And, I would snore, right? Especially if I was like in the wrong position. And so, one of the best things that I've done for that is just take a little piece of tape and put it just across my lips. And I've been sleeping that way for 3 years. And if I don't have it, I immediately know that I wake up with the dry mouth. I know that I've snored and all that, but like forcing myself just to breathe through my nose all night long, I mean, it keeps me from snoring. I mean, it probably doesn't solve everybody's problem, but I do know that it helped me, and it helped me sleep better and not wake up dry cotton mouth. And I think it also makes me, if I lay on my back and my head's up, then I'm going to snore. But if I lay on my side and my spine is in a good straight place, then I don't snore. And I think like having that little bit of tape forces me to get into that position. Otherwise, trying to snore through your nose is a little bit different, right?
Right.
So So yeah, it's a little something that I've done. I totally get with that on the nitric oxide and
Yeah.
the way that you breathe. So
I'm so
important
glad that
because
yeah, glad you brought that up because yeah, I failed to mention that, but mouth taping can be a great adjunct to everything else for sure to boost nitric oxide and just improve our restful sleep so that we feel more
yeah,
refreshed in the morning. And then the other thing, I do love the Neo 40 professional product. Like I believe Dr. Thomas mentioned that,
hmm
and it is also a great nitric oxide booster.
right, yeah,
But
good
good
little
for you
pre-work.
for taping.
Yeah, pre-work. Yeah, it's been a game changer for me. It's actually one of my favorite hacks,
Good.
and I do not go anywhere without my little piece of tape, so it works pretty good.
Good.
So yeah. Um, I hate to put you on the spot, but I got to ask this question. What's your take on statins? I get
Yeah.
so many questions on this, and I just wanted to, from an expert, kind of hear what you have that, because I think there's a little bit of distrust with the just kind of medical professions and stuff, and it's like if you have anything outside of LDL below 100, you're going to have somebody want to put you on a statin. And so I think there's plenty of research out there that shows that long-term use is optimal. So if you don't mind, just kind of open that can of worms for just a little bit.
I will. Yes, I'm glad you asked. So there is a place for statins, in my opinion. It is a love-hate relationship I have with them because I don't like, as I said earlier, any prescription medication because they are poison on some level. So it's not to be doled out like candy, like you see in many practices where cholesterol such and such, LDL such and such, we're putting you on a statin. And I know there are guidelines that support that use of the statin medication. But let me just toss out another, and this is not my idea, and it's not original with me. The thought leaders in the world of heart attack and stroke prevention and improving arterial health, based on the science, say if there is evidence, remember I said earlier, if you have a 1.3 millimeter plaque in the wall of the artery or larger, then you have vascular disease, you have atherosclerosis. So there are some people doing my kind of work that say that's my line in the sand. If you've got a 1.3, 1.4, or anything else, even one of those, then I'm going to have a conversation with you about a statin. And I say it that way because it's always education and recommendation, tell you what I would do, but it's the individual's choice. And I have a lot of people that don't want to take statins, and that's fine. I just give them the education. But the reason that many colleagues say that, and I would say in that situation, my preference is a statin, but I make the decision also by looking at those inflammatory markers you talked about earlier. Let's say somebody has no elevation in the inflammatory markers. How significant is the plaque? Meaning not how big. Remember I said a 1.3 millimeter plaque can still cause trouble, but how much of it does the individual have? Did we just find one little spot, or it's in multiple locations? They've got a lot of plaque. That would be another factor. Their age, their other risks. So there's a lot of things to go into prescribing a statin, and then of course careful monitoring. The other thing, like I said earlier, is if it is just a lipid issue, then I would definitely start with diet, exercise, lifestyle, and then add in niacin like we talked about. It's far more effective at just getting those numbers where you want them to be, as well as reducing inflammation. A statin, the reason that it has a role is that it is the best, specifically in the artery wall, potent anti-inflammatory medicine we've got. And I can't wait till something better comes along that hopefully isn't a medicine, but that's a supplement. But if you've got the Lp(a) problem, niacin is a better choice for you. Or in some high-risk individuals, niacin plus a statin. And I do understand it's not without risk. So we talk about those in great depth because and I have patients that don't take the statin for a while. We can't get inflammatory markers where we want them. Their labs look worse in a year. I mean, their arteries look worse in a year or whatever. And they finally say, okay, I'll do it for 3 months and let's look again or something like that. So to me, it's not a yes, no problem. The other thing is to pick a statin based on the individual's genetic predisposition, because there are some statins that, based on your pharmacogenetics, is not a good choice for a certain individual. So I always look at the genetics, and most often use Crestor or rosuvastatin for two reasons. One is most genetic types can take rosuvastatin without any untoward effects. And the thing I love about Crestor or rosuvastatin is that there's a huge dose range. It comes in a 5 milligram. In Europe, it comes in a 2.5 and a 1.25. But in the United States, it comes in a 5. And so we can start with a teeny tiny whiff of a dose. You can get a 5 milligram, break it in 4 pieces, and take a tiny amount to reduce the likelihood of side effect. And I've seen it markedly reduce those lipid numbers. And then, of course, we go up as we need to. So a lot of times the problem is with problems with statin, let's say with muscle inflammation, it can flare up, like you elevate your creatinine kinase and get myalgias and things.
Yeah.
Is because it's low in vitamin D or low in coenzyme Q10. So that's something to measure and keep in mind if you're putting somebody on a statin. Getting those levels where they need to be and using just a teeny tiny dose is often all you need, if you need it.
Yeah, I think, it's personalized, right? And you just explained a lot there, and it takes time, and you need somebody educated, and you need somebody who knows a lot of this, who's been through that. So that's why, like, having someone like you would be perfect in somebody who is wanting to know more and wanting to dig into this a little bit deeper. And I think, as I was saying, it's kind of the trust issue, right? And when you give somebody the options, you like lay it out for them and say, this is where it's at, then, that gives them a little bit more confidence. And then, like you said, give them a chance to try to do it through lifestyle and all that. And then, if it does still not work, and then again, let's try this, and let's try it in certain doses, right? And let's not just give up one dose and go with there. So it takes a lot of, steps and somebody who's really working with you. And so I think that's where you come into play, and the Prevent Clinic, and having somebody like you, because it's a cardiovascular health. You mentioned it, with the blood-brain barrier, right, and getting across the endothelial wall, and it's very much like gut health, right? So if you have leaky gut, then you got things in your body that you don't want. It's going to cause inflammation. It's going to cause all these things. So it just works hand in hand with keeping that optimized, keeping it healthy, making sure that you're doing everything right. Now, so there's obviously people can come to you and get help from you, but what would, like, if someone was wanting to talk to their general practitioner or something like that, and wanting to get a little bit more understanding besides just a lipid profile, what would you tell them to look into? What would you tell them to see if their doctor would run a test that maybe has the LP-LA in it or something like that? What would be the next step?
Yes, absolutely. Great question. I would say the next time that you're going to go to your doctor, here are the things you want to ask for. One is, as you said, with my lipid profile, please also add LP-A or lipoprotein small lowercase a. With my HS-CRP, the C-reactive protein, which is commonly ordered every year on an annual exam, add at least 2 other inflammatory markers. And one is, we call it MPO, but it's myeloperoxidase, an enzyme that, if elevated, there is increased white blood cell and macrophage activity in the wall of the artery that can be dangerous. Myeloperoxidase, the activity of the enzyme, and then plaque-2 activity. Plaque-2 has been around a long time. We first measured it as the mass and now we measure the activity of plaque 2 in the wall of the artery. And so when I talked earlier about a prevention emergency, if those two are elevated, that is the highest risk situation. Even if I haven't looked at your artery wall, I know you have arterial disease when one or two of those is elevated, because activity is occurring in an atherosclerotic plaque in the wall of the artery. So those two tests, along with your C-reactive protein and the Lp(a), I would say the other thing I would talk to my dentist about, to my doctor about is, well, first you do want to talk to your dentist as well, because periodontal disease and this airway issue we talked about can be a big contributor. But back to your healthcare provider, you want to talk about insulin resistance and prediabetes in depth with them, because that's a diagnosis, if you will, or a problem that's often missed. And you can take control of that at home, for one, by measuring your waist. If women are above 35 inches, men are above 40, you have insulin resistance. And so you can continue to measure your waist. And as that goes down, know that you're adding years to your life, because you've improved insulin and glucose metabolism. The other thing you can do, if you have a lipid profile that your healthcare provider has run recently, pull that out and put triglycerides over HDL. So triglycerides over your good cholesterol number, and divide. So take that ratio, triglyceride HDL ratio. And if that's above 3.5 for Caucasians, 3.5 or above, you have insulin resistance. You've got the diagnosis. You have prediabetes, and you're headed for diabetes. So that's a conversation we need to have. What do we do about that? For Hispanics, it's 3.0. And for people of color, African American, Black community, it's 2.0 for that triglyceride HDL ratio. So again, you can get that yourself if you've got a lipid profile. And from there, coenzyme Q10 is huge. Vitamin D is huge. Probably you're having those tested at the doctor's office. Also, there's 2 cardiac markers. I would say not everybody has to have these, but know that there's cardiac markers you can run, just simple blood tests, 2 of them, that tell us if the heart is struggling for enough blood right now, even in that capillary level. One is called BNP, or beta natriuretic peptide, and one is called troponin T, and both of those are the high sensitive versions. So those are critically important. And hormones and thyroid, how to optimize hormones and thyroid to reduce your risk long term as well.
Yeah, and I think that's so important, especially with the female population, postmenopausal and all that, and just making sure they're maintaining their muscle mass, and that's going to be so critical for them going forward. So it would be, ask for, Lp(a), right? And your inflammation, which was the C-reactive protein plus the MPO, and it was the plaque activity, right?
Right, that's right.
Okay. And then let's see, you could do the ratio of triglycerides to HDL, was it?
Correct. That's correct.
And there was 3.5 for Caucasians, 3.0 for Hispanic, then 2.0 for African American. And so those would be a good start. And you talked a little bit about like measuring the arterial wall and how is that done? What do you do there?
Yeah, so there's we start by getting clues. You can imagine like this picture. Where is that picture? Right here is the aortic root. If the heart was in the picture, it would be right in the middle there. And that's like the roots of a tree, but that is what gives the blood supply to just the heart. So we want to try to look at the arteries, and it's a daunting task, because you've seen the picture of the man or the woman with the arterial system, and it's massive, these highways and byways that take the nourished blood to the vital organs. There's only one way. So I'm going to talk about 5 ways real quick. There's one way, that only way you can directly visualize the artery in the body is to use an ophthalmoscope and look at the retinal artery in the eye. So we work together with our ophthalmology friends because the technology is getting better and better to be able to visualize the wall of the artery. You can imagine that that artery and many others are as small as a human hair. So to try to blow that up enough to be able to understand what's going in the wall of the artery, the retinal artery has just really been too small. May always be, but if there's some abnormalities there, then you know you've got a problem. So that's one way, is to talk to the ophthalmologist, see if there are any clues there. Everywhere else, I say, it's trying to look inside the window of a house and see if the other wall on the other side of the room has been thoroughly painted or if they've missed some spots. It's kind of really hard to tell that far away, but you look in every window and everywhere you can. So one way is to look at the heart arteries with either a CT scan, so the CT coronary artery calcium score test. It's become very inexpensive, anywhere from $40 to $100 most places in the United States. It's a very quick test. You are exposed to a little radiation, but if there's the presence of calcium in the wall of the arteries of the heart, then you have arterial disease. It answers the question yes or no in terms of arterial disease if it's a yes. If it's a no, again, think like you've looked in one window of the house, but you haven't looked everywhere. You haven't looked at all the walls. So you go from there. You can also do a coronary angiogram, but that's a little bit more involved. Nonetheless, ultrasound is one of the ways that's obviously it's not painful, it's quick, you're not exposed to radiation. And traditionally, ultrasound has been done with flow velocity for us to understand if there's a blockage, a reduction in blood flow. And so the radiologists that read it were just used to reporting that. So, you know, no reduction in blood flow or 80% reduction in blood flow due to the flow velocities. But now more and more centers are adding to that what's called B-mode ultrasound, which is a careful evaluation of the wall of the artery with a look in the carotid arteries, the femoral arteries. Those are the two most commonly looked at. And so in the common carotid artery, internal and the bulb and the internal carotid artery, that's really the biggest area where we can analyze the wall in, you know, all of the near wall, the far wall, all areas, and measure to know if it's thickening or if there is indeed plaque. So B-mode ultrasound. And even if you're getting let's say a carotid Doppler because your doctor's concerned about cardiovascular disease or cerebral vascular disease blockage, now more radiologists are at least commenting on the artery wall because the importance of it, picking it up earlier and earlier and earlier, even if there's no reduction in blood flow, they'll say significant plaque, mild plaque, and occasionally they'll give measurements, which is incredibly helpful. The other thing I'll say about that is if you had an ultrasound of any artery, let's say you have an ultrasound of the aorta, an ultrasound of any artery in your body, pull that report out and see if there's evidence of calcium there. If they've mentioned that there's calcium, then again, calcium is one of our body's ways to try to stabilize plaque. So if you've got calcium in any artery, you've got plaque. And by the way, occasionally it will be mentioned on a woman's mammogram. Now, just presence of calcium is one thing. It has to say it's in the mammary artery. So it's got to be in a blood vessel. At your dental office, sometimes they'll see calcium in the carotid artery on a full mouth x-ray, for example, or on this CT. And so when I say, you know, many ways to look, one is just starting with your medical history like that. If you've got some of those tests in your old records, pull them out to see if there might be some clues there that you've got arterial disease. So I'd say once we understand a baseline assessment, then we really do use that B-mode ultrasound as our workhorse to monitor progression or regression of disease. Certainly we can use more invasive procedures like, you know, in the cath lab, but to be able to do it in the office setting, get a baseline and look again in 12 months. And for my patients every year to make sure nothing new has popped up, things are still stable, and the disease process is regressing.
Right. So it sounds to me like, I mean, you could know years and years and years ahead of whether or not you're going to have a problem. So doing something like this, I mean, could just, make a huge change on your life for the next 10 years or something like that.
Yeah.
Yeah, I mean, obviously, we're all about optimization and all that, but taking care and preventing is also part of optimization too. And so I think we're going to have to do another call here. I know we were like, oh, it'd be 30, 40 minutes. We're just about to cross 50 minutes. So,
wow. Okay.
But yeah, this has been great. And I think we've got a lot here to unpack. I'm probably going to have to listen to this a couple times, and I'm sure everybody else listening and has followed along will probably need to do that as well. But let's plan another one, and I want to talk to you a little bit about, like, I think I sent you some information on like training and like, exercise and whatnot, because I think we have, and we see this a lot in our shop. We have, obviously the people, you can be sedentary, right? And that can be a problem there. But then you have the other side of the coin, which is the overtraining, right? And I think that is much more prevalent than we think it is. And there are so many people doing too much training out there. And in fact, that's kind of one of the places that started me down my optimization journey, was overtraining, right? And so, just how that relates to cardiovascular health, maybe we can dive in that too in another day and stuff, but it follows along with what we're discussing here. But I want to be respectful of your time today and let you get going here. And anyways, if anybody wants to find out more about Gina Pritchard and her practice, you do a whole assessment, right? It's not just come in and a couple things. You're looking at everything. You do the epigenetics. You probably do the testing that we talked about, obviously, but then the ultrasounds and whatever. I don't know what version you do, but you're looking at the whole systems approach versus just, focusing in on one or two things. And that's what I love about what you're doing. So if anybody wanted to connect to you, what's the best way to do that?
So go to thepreventclinic.com, I would say, and you can, send me an email there, or send me an email at drgina@theprevent clinic, or info@theprevent clinic, which is the, email on the website. And there's a phone number there as well. And then there's also an assessment, a little quiz you can take on the website. And the reason it's important is it makes you think about some of these things we talked about. Have you ever had an abnormal, anybody seen calcium in one of your arteries and things like that? But it tells you your subtype. Like at the end of that quiz, you'll get an email with your personalized report saying, looks like your problem could be in the area of diabetes, heading towards diabetes or insulin resistance, or your problem is lipids, or genetics, or you need genetics tested, etc. So, and if so, that'll connect us via email if you take the quiz. But even if you don't want to take the quiz, just shoot me an email is probably the best way. info@thepreventclinic.com.
All right. Yeah, and I see that up there. Take the assessment. Yeah, and I think I'll take it too. Okay. My father, he had not at an early age. I want to say it was early 50s. He had a heart attack too. So I just kind of, obviously I kind of know my genetics and stuff, but I just want to stay on top of it. And I'm sure there's lots of people out there who have family members who have suffered from cardiovascular health. Like we said, it's the #1 killer. So yeah. But anyways, well, thank you so much for your time. I really enjoyed this. I could have kept going on. It was
me too. Great fun. I really appreciate this opportunity. Yeah, I enjoyed it.
Yeah, me too. Okay. All right. Well, we will talk soon, and we'll end this broadcast. And thanks everyone for joining.
Thank you.